Hello everyone and welcome to the Dyslexia Life Hacks Show. I'm your host Matthew Head, and in this episode I'm talking to Arun Iyer. He's a medical director for Health Partners Group. After training at London Teaching Hospital, he moved into occupational medicine and has gained experience working under the supervision of a consultant occupational physician. As you may have guessed, this episode we're going to talk a lot about occupational health and dyslexia. As always, I'll put links to things we talk about in the show notes, which will be available at dyslexialifehacks.com/podcast. Welcome to the show.
Thanks very much, Matt.
That's okay. What I wanted to do before we start diving into the occupational health stuff is really your early experience with dyslexia. When did you, in your life, did you become aware of what dyslexia was or who neurodiverse people were?
So I would say that probably at medical school, to be honest. I mean, I was at medical school 2003 till 2008. So I'll be honest, it wasn't the largest component of our course, but it was touched upon. And I would say that dyslexia was the most commonly talked about rather than the other neurodivergent conditions that we hear about today. So I'd say that it probably was medical school, but then, to be honest, whilst I was in hospital medicine, it wasn't something that you came across. I think I had one colleague who was dyslexic and who was very open about her dyslexia, particularly in sort of written medical notes that, you know, she would always say apologies for the quality of my notes, but that was about it. And then it's only really when I came into occupational medicine, you started getting referrals essentially for individuals who worked for organisations.
Yeah.
And it was that route, and that's predominantly where it's come from. And as you can imagine, over the past year, particularly if not 2 years, it has really exploded in terms of awareness and referral volumes.
Yeah, I can imagine. So you didn't sort of have any children at school that you were like classmates, like, where did they go? Why did they get more time in exams? There wasn't any of that.
No, there wasn't at all, actually. And I would say that probably, again, in those days, particularly primary school, it just wasn't that known of. It was always put down to other things that, you know, and thinking back, I remember some of my classmates in those years were inattentive, but it was always just put down as disruptive and just naughty. That was it. It was the usual stuff. So
yeah. The good bad old days. Yes.
Exactly.
Okay. So obviously school, college, start studying medicine. What got you into occupational health?
It was by accident, in all honesty. I mean, I was doing surgical training and doing a PhD at the same time in an area of radiology and surgical research. But at the same time, I was kind of self-funding. So I worked for a company who did kind of medicals, but who also did occupational health. And so I started getting some occupational health referrals and just fell into it that way, and actually quite enjoyed what I was doing. And also at the same time, NHS training pathways, particularly in surgery, were changing and becoming more difficult. And you know, occupational medicine, even now amongst the medical community, is not very well known. Trainees in medical school, you either have hospital medicine, hospital surgery, or GP. People really don't know what occupational medicine is, and so there's very little awareness unless you kind of fall into it by accident, which is what happened for me. Happy accident.
I see. You thought surgery, no. Occupational health, yes.
Yeah, exactly. Yeah, definitely.
So you were, I'm trying to walk through your sort of career. So how did you get into medicine in the first place? What kind of drove you to go to university to study medicine? Because you must have been at college, and it's something I don't know anybody in the medical profession. So it's something I'm really interested in. What sort of drives you to go, yes, that's what the career is for me?
Some of it, well, a lot of it is family. So I came from quite a medical family, not directly through my parents, but my uncles, my aunts, my cousins. And, you know, it's not to sound like a stereotype, but it is, you know, in Asian families, it's kind of, you know, the sciences or law or finance. So for me, you know, but there was always the interest. My dad was into his chemistry, and then he was a research scientist. So there was always that grounding there anyway. But it is, you know, I still feel that medicine is vocational, and you do still need to have that desire to help people essentially. Otherwise, it's never going to be a vocation for someone to follow through on.
Yeah, I can imagine. Yeah, you've got to interact with people all the time and help them. If you do it because there's pound signs rolling in your eyes or other external pressures, it's definitely not going to be the job for you, is it?
No, it's not. And look, yes, you can earn a good salary eventually in medicine, but it takes a lot of time to get there and a lot of student debt and a lot of hours worked as well.
Yes, I can imagine. Yeah, and you got to be almost you got to be at PhD level as well, haven't you? So it's a fair investment in your education to get through to it. Okay, so what's the day-to-day life? Before we start diving into dyslexia itself, what's the day-to-day kind of life as an occupation in occupational medicine? How does that look like when you're doing all the assessments, and what do you do on a daily basis?
So what we essentially do is we get referrals from clients. So our company has a number of clients across many sectors. It may be professional services, it could be manufacturing, and then sort of safety critical work as well. So it's a wide sector of clients. And so what they would do is send us a referral for an employee who has a physical health problem or mental health problem or a neurodivergent, and then ask us for advice. So it could be that the individual has performance issues at work, or they're struggling at work, or their attendance is impaired as well, or a combination of all. And then we would essentially, nowadays we do a lot of remote consultations. So we do telephone consultations with our patients. Before the pandemic, it was predominantly face-to-face. And you would essentially take a full medical history and talk through the most relevant medical problems. And then also it's really important, as the name implies, for us to kind of explore the occupation as well. So understanding what the person does every day and what their perceptions are as well. So what they feel they're good at and what they're struggling with and what support they feel they could benefit from. And then essentially we're usually asked a list of questions to respond to in a report that will go back to HR or the individual's line manager. And so we would talk through those questions and then take informed consent from the employee so that they're aware of what we're putting in our report. And then that would go back. And essentially what we're doing is trying to help keep people at work. There is very sadly a misconception that occupational medicine is about only, or that occupational medicine is used when individuals are essentially being tried to be managed out of organizations. So we're kind of seen as the bad people. So if you're sent to occupational health, then that's a problem. And people can be really anxious, unfortunately, when they speak to us. They work themselves up quite a lot. And it's a shame, because our primary purpose is to keep people at work healthy and well.
Because correct me if I'm wrong here, but it could be anything from somebody's had a serious accident where they can no longer, like a limb's got nerve damage, or whatever. Their brain performance is the same, but they're sat at a desk, and I guess you have to recommend equipment that facilitates them still working to the level they did before.
Exactly. Yeah, exactly that. And we have a lot of our referrals are individuals who are about to have treatment for cancer, or who are returning to work from cancer, and it's kind of commenting on their fitness for work and adjustments like phased returns. But exactly that, it's not always cognitive. It can be very physical in nature in terms of the adjustments that we recommend.
I can imagine. And I suppose in my mind, I'm thinking of all the physical things, the chairs, the tests, but is there some internal stuff you're also doing as well?
There can be. I think, as you said, a lot of what we're recommending is the physical stuff. But we will also signpost. So nowadays, it's not just that occupational health physicians or nurses work in a silo. So we do now work alongside physios and mental health practitioners and neurodiversity assessors and things like that. So we will make onward referrals sometimes, or make recommendations that there should be onward referrals. So it isn't just, right, here's your advice and that's all that we can offer. We will try to be more holistic as well.
Okay. So let's sort of start diving into and unpacking dyslexia from the occupational health perspective. What I'm going to do first, and then we can expand out of it, is that, say, person X, we can give them a name if you'd like, has been referred to you. I've got a list of things, and you see dyslexia on the list. What is your immediate kind of process from that?
So with what we would do, so if the main sort of comment in the referral is dyslexia as the reason for referral, then it's always really important for us to understand from the individual, obviously, the history of the dyslexia. So when was it picked up? Because nowadays you still can get quite a few which are picked up later on in life rather than earlier, particularly in the working population. So it's always important to understand that. And then really, how does the dyslexia affect them? Because everyone has different experiences with dyslexia and different severities.
Yeah.
And then really understanding the job role as well, because if someone has a very computer-based role, so if they're doing lots of reports and lots of reading, lots of writing, and minute taking, things like that, then yes, perhaps the dyslexia is going to affect them more, rather than if they're predominantly on the telephone and interacting with someone in a verbal capacity. So it's that's how we would approach it, is really just trying to understand the history of the dyslexia, and then how it affects that specific individual, and then how they feel it affects them in the context of work. And seeing if they recognize, because quite often coupled with that, sometimes it will be that performance concerns are raised. So the quality of the individual's work, or the amount of work that they get through, is not as much as would be desired. So trying to understand, do you feel, is there a deficit? Is there a problem? And what do you think is the reason for that? And then the sort of output is really from there on looking at support measures in the workplace. So I'm sure yourself and the audience are aware of organisations who do support neurodiverse conditions. So Lexic, as the name implies, was one of the first that was set up specifically for dyslexia, but now supports other conditions as well. And then there are others as well. So Genius within our company, Health Partners, we've got our own in-house neurodiversity assessors to support our clients. So it would then be really signposting to our specialist colleagues to do an assessment in terms of a workplace needs assessment.
Yeah.
And then that's looking specific at the condition and the role, and then coming up with relevant adjustments, be that equipment or extra time or mentoring, coaching, all sorts. And then really just getting all of that information back to the employer so that then they can start implementing adjustments wherever feasible. And the purpose of that really is so that the individual has the best chance of success at work. Because that's the end point. It's not to say that an individual can't do the job. And I think that's, quite commonly been the assumption in the past is, well, is this person fit for work? Well, yes, they are. They just need some adjustments to help them.
So do you get a lot of people come to you when they start a new job and they put it on their application form, or do you tend to find it's more people who are under performance reviews and suddenly it's a sort of red flag has flown up, so to speak?
That's a really interesting question. What I would say is that probably in the past couple of years, where there's more awareness and more willingness to disclose conditions, we will get it on new starter questionnaires. And it depends how much information we get. So, for example, if someone puts on their questionnaire before they start a job that they've got dyslexia, but it's very mild and it's not affected them in the past at work, then perhaps we won't escalate that to a consultation with a nurse or a doctor, because it doesn't seem to warrant it. But if someone does just put dyslexia and we look at the job role and we can see that probably it is going to be quite heavy on written work or interpreting written information, then we would organise a consultation. But we seem to be getting more people disclosing neurodivergent conditions nowadays, although some sectors are still falling behind.
Okay, so you link sort of normally with access to work. Does that tend to sort of go hand in hand? I know access to work is jokingly a greatest secret going.
So access to work, it wouldn't automatically go hand in hand. I mean, it very much depends on, from our side, so what we do is corporate occupational health, so private sector occupational health. And we do look after a lot of government organisations as well, as do many of the other OH providers. But it very much depends on what services each contract has aligned with it. So if they've got a third-party provider for their neurodiversity assessment, such as Genius Within or Lexic, or if they're commissioning it from us directly, then certainly they would use those. But access to work is also there as a workplace support measure. But as you may know, it is very much a self-referral for the individual to do rather than for an employer or occupational health. So again, it's something that we can signpost to, but if we know that they've got other routes of getting adjustments, then we would recommend those.
Okay. That's interesting. So, because really, I suppose where you come in depends on how much the organisation is turned onto it, whether they've already got yourself, Lexic, or any of the other companies you've listed as allies before a new staff team got in. So, they put it on the application form. Let's go for that example. And suddenly somebody, when they start within a week, gets the phone, hey, let's have an occupational health assessment. And then they suddenly think, oh no.
Exactly.
What is this?
Yeah, exactly.
And if they come into you and you're about to do an assessment to them, I mean, you don't have to just tell me how all the sausage is made, but what sort of thing happens if somebody's listed this and they think, I've got this next week, what can they expect?
So first thing to remember is it's supportive. So with the Equality Act, so pre-placement questionnaires are there for the purpose of identifying someone's fitness for work, but in the sense of, is someone fit for work without any adjustments or restrictions, or are they fit for work with adjustments, essentially? It's incredibly rare that you would have someone coming to a pre-placement sort of appointment with the premise that they're not fit for work. And the only real times that happens is if there are statutory requirements. So if someone is required to meet certain standards of fitness or vision or lung function or something like that, because they're in a job that requires a level of vision. So take, for example, Group 2 sort of LGV drivers, they need to meet DVLA requirements. And if they can't do it, then we can't pass them fit. Simple.
Yes.
But for your office workers, I don't think I've ever passed anyone as unfit based on their medical history. So I think that's the first thing that people should try to remember, because I think it is very much when I do these consultations, when I say, first thing to say is you're fit for work, you can hear the sigh of relief because they're so scared. They've already served notice in their job and they're just thinking, oh God, now I've got this hurdle to get through. But it's not a hurdle. It's really what the purpose is that we're trying to identify those adjustments and support measures from day one. So it's not that you get to the job and then there are some problems and then you get referred and it just delays everything. Whereas if we can get the advice in before you even start the job, it means that you can have a conversation with your manager and then things are a lot more smooth. So everything that is there, the premise is to support you and to help you succeed in the job. Yes.
I remember starting a new job, and as you say, you've got all the wheels in motion, and suddenly it's like, you need to go see our doctor.
Yes.
What? But I'm sitting behind a desk all day.
Exactly. Yeah. And I think, again, it's just, there is a very severe lack of understanding and awareness of occupational health.
Yeah.
And that's across the board, even amongst medics who are, the only time medics will really come across occupational health is when you go for your Hep B jabs and tests. That's it. You don't really have any other experience of them.
Okay. Yes.
So it's an unknown specialty in terms of what we do.
Yes, it is. Yeah, it's not something you hear about a lot. So, okay. Now, I'm curious, really, what sort of interventions happen? Let's start with somebody who is an office worker, because I imagine you get a few office workers with dyslexia that, as you say, you've already sort of alluded to a few times, as written tasks and things. Come to you for an assessment. Assessments, you've found some things that you can assist with. I know two dyslexic people aren't the same, but like kind of as a general thing, just to get a feel for what you do post-assessment, what kind of things are you recommending then?
So, I mean, it could be things like software, so computer software. So nowadays with Word documents and things, you've got spell check, which is straightforward to use. So that can help for someone who has difficulty with their spelling. Then there's sort of text to voice as well. So if individuals have difficulty reading, then that can help just to automate the process. And then it's the sort of adjustments around performance expectations. So obviously if someone has dyslexia and it takes them longer to do tasks, then we would be encouraging that, consider extra time and extra support to complete those tasks. And obviously if someone's going to have extra time, then that may affect their productivity. So they may not be able to get through the 10 or 12 cases a day, for a caseworker that they're expected to do, and perhaps adjust that to 6 to 8 so that it's a more level playing field when it comes to performance management processes further down the line. So it's those sorts of things. I mean, for dyslexia specifically, there are fewer sort of adjustments that are recommended, because most of it is fairly straightforward in terms of the existing software packages that are out there. And we don't ordinarily associate a higher level of sickness absence with dyslexia. And it's one of those conditions that we don't really expect it to flare up either. It's there all the time, and it's really just how do you help the individual manage their symptoms in the context of work? And usually it is just around, ensuring software is there. As I said before, we do sometimes will refer on to the more specialist neurodiversity assessors who can give the whole list. And sometimes it is about coaching and training and mentorship as well, because confidence can be lacking, particularly when you start a new job. So just ensuring, again, regular contact with a manager, regular feedback, so because there's nothing worse than getting no feedback until you're called to a performance management meeting. So it's definitely. So it's just encouraging transparency and just the soft skills approach, really.
Okay. And one thing I'm curious of, so there's quite a lot of co-occurring neurodiversities, isn't there? So you like to get somebody like dyslexic and ADHD and things like that.
Yep.
How does the picture change when you start getting co-occurrencing?
It does make it a bit more complex, because and you're exactly right. You can have co-occurring neurodivergent conditions very commonly, and also with mental health as well, particularly if there's been a lot of masking for a long time. And that's more around the autism and Asperger's side, but it certainly does come across to us in occupational health frequently. So in those sorts of situations, it is much more important to have the workplace needs assessment done through the third party sort of neurodiversity specialists, because they will be able to identify which strands of which condition are more likely to affect the individual at work. And then identify more targeted interventions in terms of the adjustments that should be considered, and increasingly that's what we do nowadays. We do ask our colleagues to do that for us, and they're well versed in giving good tailored adjustments which are of benefit.
What's the sort of workflow for that? Is it the person to you then almost sub that out to a specialist? Does it then come back through you before it hits the sort of person that you're dealing with?
It really depends on the company, and that very much the occupational health provider as well. So for us, it may be something that we pick up at triage. So when we look at the the outcome report from the pre-placement questionnaire or the referral further down the line when the individual's already at work, we would take a look at what we're being told, and then we'll decide, right, does that need to come to an occupational health physician or nurse, or would it be better off just straight away going to the neurodiversity team?
Okay, yeah.
And it could be that if it came to us, so if it came to the occupational health physician or nurse, then we would be able to then refer onwards directly to our colleagues into the neurodiversity team. And then they would provide a standalone report as well that goes to the employer and the employee. So it wouldn't need to come back to us and then us to do another report.
Okay. How are you finding, obviously with the COVID-19 pandemic's accelerated the working from home, how are you finding that shifting gears in terms of your job as an occupational health provider?
So it's been interesting. I think particularly 2020 was difficult, and interestingly for many years where office ergonomics had been improved, so that people had really decent chairs and really well set up screens and then height adjustable desks for some people, we saw a lot less in terms of musculoskeletal conditions coming to us, in terms of back pain, neck pain and stuff like that. And since then it's been creeping up again. Because unfortunately, I spoke to employees in 2020 who were working in bed because they didn't have room for a desk and chair. And so it was terrible ergonomics that people were working in. And so they ended up with all sorts of musculoskeletal conditions.
Yeah.
But equally, I think I wouldn't say that there was a definite uptick in people struggling with dyslexia at home. And I think for some people, actually working in a quiet environment with no external distractions was helpful. And some of my patients have found the hybrid way of working now helpful in terms of they've got a couple of days at home with fewer distractions and they can concentrate more effectively on their work rather than in busy office environments where they're prone to distraction. But again, some of my patients with other neurodivergent conditions, they have struggled a lot more because they need the routine of getting up, going to work, working in an office environment, having a really structured day and being around others. So it's really been a very mixed bag. And that's why I think early on, where last year perhaps there were lots of people saying, going back to work in the office is never ever going to happen again. And for actually some of my patients, they were really worried. They were just, I wouldn't be able to cope in that sort of situation. So again, it's looking at the individual. It's not a one size fits all. And certainly, some of my patients with neurodivergent conditions, they much prefer to be in the office 5 days a week. Some of them have 4 days at home because it just works better for them.
Yeah. It's nice with the hybrid working. You could tailor it because, having had a job where it's like work from home all the time and you're like, yes, this is awesome. And then, I need a whole different toolkit for this.
Exactly. And I think, look, it was a for all of us, it was novel because we'd never ever done anything like that. And then I think we got into last year and certainly beginning of this year, and I think people were just chomping at the bit to be back in the office at least part of the time and being around others. It's been amazing to see how the City of London has just gone from being completely dead 5 days a week to now 3 days a week being incredibly busy. So
it's funny, isn't it? It's I think some of the team cohesion and some of the interactions has been lost when we work from home, and it's not quite the same on your Zoom screen, no matter how big your Zoom screen is.
No, exactly. And again, for some people with autism and Asperger's, where social interactions can be difficult, and yes, it can be difficult in person, but they can find it even more difficult on screen and then not wanting to be on screen.
Yes, of course.
So it can be very isolating. So I think it's just trying to recognize how different ways of working affect different people.
Yes, most definitely. There's no one size fits all, is there?
Definitely not. No.
So you touched on ergos earlier when we talked about working from home and people working from their beds or the kitchen side table and all that fun stuff. Now, I have seen some stuff pop up in neurodiverse circles about ergos and maybe having chairs, and even with dyslexic people, that people move around and the ergonomics. Have you heard anything about that? what is sort of thinking on
that? So I would say that I have come across some in terms of ADHD patients, and I think that is more to do with maintaining concentration. And so again, having a structure to each hour of work so that they know that they're sitting for a set amount of time to work on a bit of work, then standing for a bit of time, then walking around for a bit of time. It really helps them to focus for the day.
Yeah.
And so the ergonomics can come into that in terms of having a sit-stand desk, for example, which allows them to stand up and then be more productive during that time when they're standing, rather than them just not working during that time. So yes, I have come across it, not very often, I'll be honest, but it has come up occasionally when I've spoken to patients in terms of, well, how do you get on at work and what sort of things do you do? And it's just really interesting just to hear from different patients in terms of their different experiences of how they manage their conditions at work, because no two are the same, or very rarely are the same. And it's just good to increase, as a physician, to increase your understanding, because when you have conversations with others, you could say, well, have you tried this before? And so it's just another perspective from someone who's lived experience of the condition.
Yes, definitely. It is, and I think it's nice where it's becoming something that more people talk about, that actually between dyslexics and anybody else who's got who's neurodiverse can sort of share notes and things, and I think that's really, really helpful, really powerful for people.
Definitely.
Just want to kind of turn our conversation a little bit to we've obviously been quite focused on your office worker, because I guess it's the easiest thing to start with, and you and I are both office workers, so But what about somebody who's more of a manual worker, or out on site, or in a van, whatever, and are still writing things down or whatever, and a dyslexic? How would that look differently? Because obviously you cited the software, which assumes you've got your own laptop that's tied to you all the time, but somebody says they're dyslexic and they're like a foreman or a site manager on a more manual-based job, less office work.
Yeah. It's the premise is still the same. So what we would still be looking to support them in the same manner, but I think it all comes down to what the expectations of the role are. And for someone who is perhaps a foreman on site, they may be doing very little in the way of administrative or clerical work. But clearly, if there was an expectation that perhaps half of their role is administrative, then we would still be recommending the same sort of adjustments to support them. And and sometimes we will have patients who specifically choose roles that are more manual in nature, because then they don't have to be too concerned about their dyslexia in the context of their work and what they need to do. But it is very much still the same sort of approach that we would take. We would look at what they need to do. We would look at what conditions they're reported, and then we would advise accordingly.
Yes. Okay. So, you are right, I think. And I mean, I'm guilty of this. I used to be a manual worker for that very reason, that I didn't have to write so much down. Well, so I thought when I trained for the job.
Yes. Yeah.
Until I got there in a bit of paper and a pen, like, you finished your manual work now write a story on what you did. Yes. Okay.
And I think nowadays, obviously, there's all the health and safety training that you need to go through, and being able to, and sometimes there are exams for that as well. You've got to pass tests, even whether you're site-based or whatever. And so, and that's sometimes when it can become apparent, because on pre-placement questionnaires, sometimes people won't disclose conditions they don't feel are going to be relevant, but it only comes up when they're required to sit a test or go through some sort of training program, and then they notify their manager or HR, and then we'll get a referral. And what can we do to support them and what adjustments can we consider? Yes,
definitely. It's a bit, it's less obvious, isn't it, with that?
It is. Yeah. And I think sometimes the assumption is that, okay, it's, I'm applying for a physical manual role, so it's why should I need to disclose this?
Yes. And I think some people, with their kind of internal dialogue about being neurodiverse can steer them in a way to try and run away from it, maybe.
Yes. Yeah, definitely.
It can be a big problem, unfortunately. Okay, so what I'm going to do is start winding the podcast down now. And at the end of each episode, I have 3 rapid-fire questions. They are quick questions from me. They don't necessarily need quick answers from you. So shall we dive in with question number 1?
Go for it.
Okay. What prejudice have you had about dyslexia that's been proven wrong? They're easy, these.
That's a hard one. I don't think I've really had any. And being completely honest, I don't think I have. I think it's, as I said, I mean, I didn't have classmates at school who perhaps had a lived experience with it. And certainly I think by the time I got to med school and been through training, I want to think I was a much more rounded person with it. So I didn't really have a misconception that, okay, this could be a problem. I think it was always that, that letters could be backwards. So, R's tended to be backwards of one of my colleagues when I was in hospital medicine, and just things like that, and the backward ticks and stuff like that. But it was never, it was, I don't think I'd say that there were any other misconceptions really around it.
Oh, no, that's good that you didn't have any didn't bring any baggage into it. And I imagine your curiosity going to uni and studying medicine, it's another thing to get your teeth into.
Exactly. Yeah. Another thing to support.
Yes. Okay. Second question then. If an alien landed and you had to describe dyslexia to them, how would you do it?
So I would explain that dyslexia, I would try to explain that dyslexia is part of a group of conditions which are essentially neurodivergent. So it's trying to just suggest that it is just a difference in the way an individual approaches things rather than being a disease, which is sometimes what it's alluded to. And then just in the simplest of terms, just explain that for some individuals, they can have difficulty reading or writing or spelling, but there is no difficulty with comprehension in terms of cognitive function.
Yeah.
Just trying to show the differences, really.
Yeah, that's cool. Okay, and the final question of the podcast from me, seeing as it's called a Dyslexia Life Hack Show, what is your favourite dyslexia life hack?
Look, being an occupational health physician, I think all I would say is that be open about your dyslexia in the context of work and get the support that you are entitled to receive. That's the thing. I think there's no reason why you can't have a successful career.
No.
And there's no reason why, particularly in this day and age, employers are looking to support. There are inclusivity policies, and across the board, be them Magic Circle law firms or your run-of-the-mill company on the high street, everyone is there to support. And there is much better access to occupational health now than there was 5 years ago. And there are all sorts of initiatives that, the faculty and the Society of Occupational Medicine are running at the moment. So definitely do get support, do notify your HR department, your manager, and get a referral to occupational health.
Yes, definitely. And I think even my own personal journey, how my career has shifted into a high gear since I started embracing the dyslexic side of me, it facing up to it and being open about it does help a lot, actually.
Yeah. And there is support out there. There is.
Yeah. Okay, well, is there anything you'd like to add before we sign off this podcast?
No, just thanks very much for having me on.
No worries at all. And, thank you for reaching out and taking the time to come on this podcast.
Pleasure.
And I want to thank everybody else for taking the time to listen, and I will speak to you in the next episode. Goodbye for now.